Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Hi, everybody. My name is Ashley Ellis. I am the Director for Practice Innovation for the Tennessee Heart Health Network and the Tennessee Population Health Consortium. Thank you for joining us today. We are so excited to have our guest, Dr. Wendy St. She is a professor in the College of Pharmacy at the University of Minnesota. She received her Doctor of Pharmacy degree and Adult Medicine Fellowship from the University of Texas Health Science Center. She was a clinical pharmacist at the Hennepin County Medical Center in Minneapolis, where she provided medication therapy management for patients with kidney diseases. Dr. St. Peter's career began focused on improving medication management and drug safety in patients with kidney disease. She is a co-investigator with the United States Renal Data System and served on several national technical expert panels on drug safety in persons with CKD. She served on the National Kidney Foundation and American Society NKF-ASN Taskforce for eGFR and race, and now co-leads the NKF Workgroup for implementation of race-free eGFR for medication-related decisions. Dr. St. Peter is the director of the National Advancing Kidney Health through Optimal Medication Management Initiative. So as you can see, we have quite the expert with us today, and she's going to be speaking to us about integrating the K into CKM, Cardiovascular-Kidney Metabolic Health. We are really looking forward to hearing about this. This is one of our participant requested topics that we had from back in our December meeting. So we cannot wait to hear, and this will be recorded and posted to our website. So with that, take it away, Dr. St. Peter.
Well, thank you, Ashley. I'm just honored to be here, not in Tennessee, but with Tennesseans in this really cold day in Minnesota. So I'm hoping you're a bit warmer there. And Lisa, I thank you so much for the organization for this, coming up to this meeting. I'm really excited. I'm going to share my screen. Today, what I want to talk about is integrating the K, or the kidney, into cardio, metabolic, and kidney syndrome. And today I hope to bring to you the intersection between cardiovascular, kidney, and metabolic diseases, and talk about some of the management and frankly, screening, so we can even initiate management. We have to identify first. So today, what I'm going to do is talk about chronic kidney disease first, talk about staging and diagnosing and the two tests we use, and then some pillars of medication management in the kidney disease space. And then I'm going to go into how kidneys play into this whole cardiovascular kidney metabolic spectrum, talking about the AACA and the ACC presidential advisory. It's really the AHA, not ACA. And staging, predicting CVD risk with the PREVENT equation, and then reducing CVD and CKD risk with this intersection of medication management. And lastly, if we have enough time, I'll talk about the Advancing Kidney Health for Optimal Medication Management Initiative. So why does this matter? We have an epidemic of obesity leading to prediabetes and type 2 diabetes in the US. And those are some of the major factors that lead to cardiovascular disease in the US. And then this intersecting role of chronic kidney disease. And of course, it matters for our patients. I know that in Minnesota, I think as well as in Tennessee, we have a predominantly white population. but we also have a diversity, African Americans, Hmong here, and a number of other race ethnicity groups where rates of chronic kidney disease are higher. And so why does kidney disease matter in this? It's because 1 in 3 Americans, think of that, 1 out of every 3 Americans are at risk for kidney disease, with 37 million Americans having chronic kidney disease. We have, over 600,000 of people that live with kidney failure, and that means that most of those are on hemodialysis or peritoneal dialysis or require a kidney transplant. But there's simply not enough transplants to go along, so most are living with dialysis. We also know that there are major disparities in the chronic kidney disease space. We have Blacks who are 3.8 times, American Indians that are 2.4 times, and Hispanics that are 2.0 times more likely to develop kidney failure than whites. And so this is a big call to action in these groups of people, because they are going to end-stage renal disease at a much faster rate than whites are. And really, and I know the Tennessee Learning Collaborative is really focused in on diabetes. Diabetes is the main cause of chronic kidney disease. And the second one is hypertension. So between those two intersecting diseases, over 75% of our cases of chronic kidney disease occur. We have about 25% that are other rare diseases like glomerular diseases, polycystic kidney disease. But for me as a healthcare professional, and when you think about population health, is getting our arms around this diabetes and high blood pressure and making sure that we're identifying chronic kidney disease early, and then managing patients with some intersecting therapies. Now, I wanted to talk a little bit about assessing kidney disease, because I think a lot of people understand that you can look at the estimated glomerular filtration rate and you can see, kidney function go down, that filtration function. But what people oftentimes don't think about is albuminuria, and that is albumin or protein in the urine. In patients that don't have diabetes or high blood pressure, typically you will see a urine albumin creatinine ratio that's less than 30 on a spot urine specimen. And that is typical. Sometimes you get some protein spilling in the urine with high temperatures, with a fever, or with heavy exercise. But generally, anything greater than 30 is a sign of damage to that filtration function in the kidney. And so albuminuria, we now know, is a cardiovascular disease risk factor, and it's a big predictor for progression of kidney disease, particularly in diabetes patients. So the higher the albumin in the urine, the higher the risk. And I just wanted to show you this picture down of the healthy kidney. You see the filtration barrier, that glomerular filtration barrier. You see that albumin, or the round circles above, they're not getting into the urine. We shouldn't see albumin in the urine. But in patients with diabetes, and oftentimes also with hypertension, you see that protein leaking or getting across that filtration barrier. And it's an evidence of kidney damage. And so what can we do about it? If you go to the right-hand side, you see the two tests that we need to do. One is the eGFR test. That's where a serum creatinine is drawn. And with that, we calculate an estimated glomerular filtration rate. So it's really a measure of that kidney filtration function. And then we also should get a UACR test, that urine albumin to creatinine ratio. And people with diabetes, we should be getting those two tests together at least annually. But if patients have higher amounts of albumin or lower eGFRs, estimated glomerular filtration rates, you might even want to do them more often than once a year, but at least once a year in patients with type 2 and type 1 diabetes. So one of the things before we start management of chronic kidney disease, we want to ask ourselves the question, is this an acute problem or is this a chronic problem? And what I'm talking about today is treatment and management of chronic kidney disease. So we're looking for those abnormalities, that UACR that's high or the glomerular filtration rate that's low for at least 2 months. So we can look for both kidney damage, that albuminuria, or the kidney filtration function, that is the eGFR. And eGFR is less than 60, and albuminuria in greater than 30 represents kidney disease. So the bottom line then for CKD diagnosis is you need 2 instances of evidence for either kidney damage, typically the UACR, or 2 GFRs that are about 3 months apart. Of course, you have somebody with severe albumin levels in their urine or really low GFR, you're not going to wait 3 months to reevaluate. You'll start treating, and you just need to make sure it's not acute kidney injury. So with that evidence, that UACR and the GFR, you can classify patients with chronic kidney disease. This is a heat map by the National Kidney Foundation. And what you see here is different. I think I love this, the heat map, because it's colors. Green means good, red means high risk for CKD progression or cardiovascular disease progression. So you see on the left hand, the GFR, the glomerular filtration rate categories, G1 through G5. G1 is normal. Normal kidney function is generally greater than 90. In younger people, the average GFR is about 120. And when you get to G5, that's kidney failure with a GFR less than 15, which means they have less than 12% of their kidney function left. And then you see the albumin markers at the top, A1 being normal to A3 with severely increased with greater than 300 milligrams per gram. So in this way, with those 2 markers, you can put somebody into this heat map classification and see if they're at high risk, that's orange, very high risk, red, for progression. And it's with these, earlier stages is where we want to catch people in the yellow stage. So we start treating and managing so they don't get to the orange or red, where we know they will generally progress to end-stage kidney disease. So the holistic approach to CKD treatment, or CKM, that K in the CKM, is starting with a number of different management. And one is lifestyle. I think in diabetes, that's really the baseline, right? And this will go for everything I'm talking about, no matter which stage. We always start the baseline of that lifestyle interventions and making sure we talk to patients and let them know not only that they should do it, but importantly, why they need to do it, because it sets up high risk for cardiovascular disease and potentially chronic kidney disease. So that goes without saying, but in CKD, some of the things we start talking about first-line drug therapy is ACE inhibitors and ARBs, and that's in that blue circled top diagram here, where you're aiming for systolic blood pressure less than 120 with a standardized office measurement, or greater or less than 130 with a routine office measurement. And we use the maximally tolerated dose that have been used in cardiovascular trials. So we titrate up because that reduces blood pressure, it reduces albuminuria. So it's not just for hypertension anymore. It's for patients with chronic kidney disease that has some albuminuria, greater than 30, as well as hypertension management. It helps heart, blood pressure, and kidneys. And then SGLT2 inhibitors, we know in diabetes, first-line treatment is also a first-line treatment for CKD because SGLT2s have been shown to reduce progression of CKD in a number of different situations, those with diabetes, those with or without diabetes, those with or without heart failure. And so that is a huge, huge pillar of therapy in this area. And then we've got the GLP-1s. GLP-1s now have strong evidence alongside the SGLT2s for reduction of CVD as well as progression of kidney disease in patients with both. And also the potential with both of these agents for, reducing even the development of diabetes and the development of CKD. And then we have our non-steroidal mineralocorticoid receptor antagonists. Those are not spironolactone, that is a steroidal drug, but finerenone, which is a relatively new drug that we use now and are indicated specifically in patients with diabetes, patients with CKD, or now we'll have probably indication with CKD and heart failure as well. So those are our pillars of care on the right-hand side there. More about this cardiovascular kidney metabolic intersection, again, beginning with the lifestyle-related issues, and as our obesity epidemic has progressed, we're seeing, lots of issues with hypertension, high blood glucose, prediabetes, diabetes, and those ultimately funnel into, development of other risk factors for both chronic kidney disease as well as cardiovascular disease progression. And in the kidney, we see hyperfiltration in diabetes. That causes increased pressure at the glomerulus, which causes albuminuria. Fibrosis is one of the issues with that damage to that kidney filtration barrier. And then down below, of course, ASCVD, myocardial infarctions that can lead from fibrosis, and that can also lead to heart failure. So you see the big intersection on the right-hand side between the kidneys and the heart. They work together. The kidneys don't function well. That impacts heart and vice versa. This is now moving on from just CKD. This is a classification that the American Heart Association came out with in 2023 with a presidential advisory. And what this does is now intersect these three things, the cardiovascular kidney metabolic syndrome. And so staging to this particular intersection of diseases, with stage 1 being somebody that doesn't have any risk factors, that's doing just fine, doesn't have prediabetes, does not have high blood pressure. And then the start of much of this, and especially with CKD and heart disease, is obesity, that dysfunctional adipose tissue, overweight, that then leads to the metabolic different problems, hypertriglyceridemia, hyperlipidemia, high blood pressure, metabolic syndrome leading to type 2 diabetes. And then this is where, of course, stage 2 is where we start seeing in that heat map, in the yellow, orange, and red range, that patients start developing chronic kidney disease. And then you see this little line down here. This just means these non-metabolic causes of chronic kidney disease that kind of then filter into this area as well, into stage 2 CKM. Stage 3 is when patients are starting to show subclinical signs, so not symptomatic signs of atherosclerotic heart disease as well as heart failure. And then stage 4 is the full-blown diseases, heart failure, heart disease, atrial fib, stroke, AFib. And of course, this is the stage that you oftentimes start seeing rapidly progressing kidney disease as well. I wanted to talk, I'm going to stop right now, and I want to see if anybody online, and maybe Ashley or Misa, you can take a look. Does anybody online, have they heard about the Prevent calculator?
We have had in our community partners meeting, AHA talked about this at one meeting, and then we have someone else coming to talk about it a little bit later on this month, but it's new to all of our audience, really. So we need more information.
Okay, so I'm going to talk about this in that we've had risk equations that calculate the risk for atherosclerotic heart disease, or CVD, for a long time, and we're used to using them. But now the American Heart Association has come up with a new calculator that incorporates some new pieces. And it's really important that we start gravitating towards this one, because from my perspective, what has been missing from other risk calculators is the risk that patients with chronic kidney disease with low GFRs and those that have albuminuria bring. And finally, we all have known this is a risk factor for cardiovascular disease for many years, but finally, we've got those parameters, the eGFR and the urine albumin-creatinine ratio, that is integrated into this new calculator, which now allows us to really more rigorously evaluate cardiovascular disease risk. And so I'm going to be talking about a case in a moment, but I just wanted to let you know this is what I suggest using from this point on. We need to move on from those old calculators and use this new risk-based calculator.
I think that's a huge point. If everybody take note of that, because that was going to be one of my questions, because there's been so many calculators that have changed even since I graduated. So I think it comes up for a lot of people, like, which one do I use? I want to make sure I'm using the latest evidence, what's important. So that really is helpful.
I know that some EHR are now, putting this right into the workflow, so people can automatically calculate it in their health systems. This would be something I'd be advocating for. But you can always go to the website that I've got on the bottom of these slide sets. I'd be happy to send these slides out that will also get you to the Prevent calculator. Now, what I'm going to do today is really focus in on stage 2 and 3 CKM management. Stage 1, if you remember, is mainly the prediabetes, obesity, and of course, there's some therapies there that we have to continue on through stages 2 and 3, maybe even into CKM stage 4. But I wanted to just introduce the fact that there are these 5 stages of CKM. And with each stage, there are different management steps that we as practitioners, and if there's any patients on this, that you need to be aware of so you can talk to your physicians and healthcare professionals with. I know you can't read this, so I'm going to go to the next slide that really blows up stage 2 and what is stage 2 and what do we start thinking about treating with. Well, stage 2 is typically moderate to high risk chronic kidney disease. And those are again in those yellow, orange, and red categories on that heat map. And so with UACR, urine albumin-creatinine ratio greater than 30, you gotta think about an ACE inhibitor and ARB. And let me tell you, this criteria is met by the vast majority of our patients that have chronic kidney disease. So ACE inhibitors and ARBs are that first level. They're generic, they're inexpensive. We need to have almost everybody on these at baseline. And then in patients that have CKD with or without diabetes, then we have to think of the other really important therapy, the SGLT2 inhibitors. These are the key cornerstones right now because they have so much evidence to support their use in diabetes, CKD, as well as heart failure. And so SGLT2 inhibitors that have cardio-kidney protective properties. In patients that have diabetic kidney disease that have residual albuminuria, that means a urine albumin creatinine ratio greater than 30, that are already on ACE and ARBs, you might think about finerenone as well. Finerenone has been studied, on patients with ACE and ARBs, and the same thing with SGLT2s. All those big studies have those patients have all been on ACE inhibitors and ARBs before they've gone on to SGLT2s or the finerenone. So that is another one we have to be implementing more often, and it's not used in very many people at this point. And then, of course, the moderate high intensity statins in patients with diabetic kidney disease or with high LDL cholesterol. And then patients that have high hemoglobin A1Cs, that, of course, SGLT2s, there's the GLP-1s, particularly when the hemoglobin A1C is greater than 9, patients on a high insulin dose, then, the GLP-1 RAs are better at reducing hemoglobin A1C and bringing that blood glucose down. In stage 3, this is where you start seeing that subclinical evidence of cardiovascular disease. You're seeing atherosclerotic plaques, in the cardiovascular vessels. And so what we do here is first think about CVD risk equivalence for stage 3 CKM. So with the kidney disease part of this, any patient that has red on the CKD heat map is in at least the subclinical stage 3 stage. And if patients are having a high predicted CVD risk score, and that's greater than 20% with the PREVENT calculator, those are risk equivalents that will put patients automatically into stage 3 CKM. So in patients that have CKD or not, and patients that have subclinical evidence of heart failure, we're going to, and with an ejection fraction less than 40%, we're going to use the ACE inhibitor ARBs. That's a blanket therapy along with beta blockers, which of course is a pillar therapy in heart failure. And in type 2 diabetes, you're also going to be thinking about an SGLT2 inhibitor. So presumably a lot of these patients are on them, or they should have been on them before they reach stage 3, but if not, we're thinking about intensification and adding more therapies. So when we talk about these drugs and why they have been, we've been so focused on SGLT2s and GLP-1s, especially in patients with diabetes, but now, again, as I said, in CKD, to prevent progression, you look here and you see the green coloring. These are the drug categories that have been shown to have the most benefits and oftentimes the least risk. So both of these drug classes have been shown to have beneficial properties in reducing progression of CKD, ASCVD, heart failure, especially with SGLT2 inhibitors, a lot of benefit, and then there's potential benefit. This area is under investigation right now with heart failure with the GLP-1s. And you see they have low hypoglycemic risk, weight loss effects, but the costs are high. Some of these agents will be going to generic status, if not already, hopefully in the next year or two. And then all the other drugs that we see down here, you see not so much green, and then with insulin and sulfonylureas, which unfortunately a lot of our patients are still on, especially my patient population with CKD, because they're cheap, but they don't have any cardiovascular effects. In fact, they increase weight and they're neutral for progression of kidney disease. So they're not helpful. And so they're no longer really in our lineup. And those are not agents we want to use unless we're forced to use them because we can't get patients access to those medications, the SGLT2s and the GLP-1s. I also wanted to show about dose adjustments because I am focused in the kidney disease space and which of these drugs have kidney protective properties. So you see in the red box, you've got the 3 SGLT2s on the top, enagliflozin, epagliflozin, and epagliflozin. All of them have kidney heart benefits. And you can see that all of these medications can be used and initiated if the GFR is greater than 20. So you see I've drawn a green line on canagliflozin and dapagliflozin here because even though their package inserts don't indicate it, clinical guidelines now say we can initiate any of these SGLT2 inhibitors when GFRs are greater than 20 and they can be continued on down through dialysis. Dialysis at that point at end-stage kidney disease, we don't know if they have efficacy, but we do have evidence for efficacy all the way down to dialysis. So keep those patients on those drugs. And then with GLP-1 receptor agonists, we know there's not a class effect. Exenatide does not work for reduction of cardiovascular or kidney disease. It doesn't have kidney disease benefits. But dulaglutide, liraglutide, and semaglutide are all ones that have both been demonstrated to have cardiovascular and kidney benefits. And with the 3 of these drugs that have those benefits, there's no dose reduction needed. So I'm going to stop there before we go on to our case, see if there's any questions.
I had one that did come to mind as you were talking about with some of the dose adjustments when you were saying highest dose tolerated and things like that. How often do you run into patients where it was just kind of clinical inertia and the dose didn't get adjusted for a long time?
We run into that a lot. They get started on the lowest dose of, for instance, lisinopril or losartan, and they don't go up. Or the other situation that we see a lot in the kidney disease space, or probably in the cardiovascular disease space too, that somebody attempts to increase the dose and they see the GFR go down or the serum creatinine go up. That is the same thing with SGLT2 inhibitors, which will cause that bump up in serum creatinine and that bump down in glomerular filtration rate. And that freaks people out. And that's, they end up stopping the medications because they think the patient has acute kidney injury. And that is not the right thing to do because we know those drugs, the way they work is by reducing glomerular filtration rate. So, and pressure. And we know that with the beneficial aspects of the drug, one of the things that really plays in their beneficial effect is that they lower the pressure in that filtration unit in the kidney, preserving it over time, so reducing chronic kidney disease progression. And so they have other effects as well, but we shouldn't get nervous about that GFR dip. And I tell people that unless you see greater than a 30% reduction in GFR, you shouldn't stop the dose. And even if you go to the next higher dose and you get a higher than 30% reduction, then you just go back to the previous dose. You don't stop the drug because there is got clear benefits even with those eGFR dips. So just know that with SGLT2s and ACE inhibitors and ARBs, you expect that. And don't be alarmed unless it's more than 30%. And that will cause you to back down on doses and things like that, or reevaluate the patient for things like dehydration or other medications that they might have started taking, like a non-steroidal anti-inflammatory that could cause the same thing. So that was a great question, Ashley. I'm glad you asked that, because this one, again, the third reason is hyperkalemia. So we know that SGLT2s, just by their mechanism of action, as they increase sodium loss, they also increase potassium retention. So what do you do about that? Well, cool. We have our SGLT2 inhibitors. They cause more of a diuretic effect. That's one of their actions. And they reduce hyperkalemia. So using those two drugs together, those are our two fixtures now in our armamentarium for chronic kidney disease. That offsets that issue that we can see with hyperkalemia with ACE inhibitors and ARBs. And so you just want to think about that. Also, of course, after you go through their list, make sure that they're not, eating a lot of high potassium foods, which are oftentimes high potassium, high sodium foods are in most of our a lot of our commercially available pre-made foods. Then, you start thinking about a potassium binder if you still can't do it. But we do not want to take our patients off those drugs, the RAS inhibitors. So we deal with the hyperkalemia and we deal with that GFR dip. And if it's not too bad, we just keep on marching forward, because we expect that to happen. Well, let's get on to a case, okay? So I love cases, and I think it's the best way to learn. And we have a 45-year-old man that is here. In this case, they're coming in to see a pharmacist for a comprehensive medication management follow-up. The patient has high blood pressure, type 2 diabetes, obesity, and he's already been diagnosed with CKD stage G3B, so he's at high risk. He self-identifies as African American. He's got home fasting blood glucoses between 80 and 145, which aren't great. You go down, you see his current medication list: hydrochlorothiazide and atenolol for hypertension management. You've got metformin, atorvastatin at maximum doses. So he's on high doses of atorvastatin and a multivitamin. You see his blood pressure today is high. His weight is 225 pounds with a BMI of 31. He's got some key labs here. You can see his HDL is low, total cholesterol is 135 today, A1C 7.5, blood glucose 90 is not too bad, UACR is 350, and eGFR is 40. So I have a question: is this patient at low, moderate, or high, or very high risk for CKD? And I see I've written the wrong thing in the square. It's actually very high risk, because he's in red, very high risk. Sorry about that. I was just doing that this morning, right before this. So this guy is at very high risk for progression of kidney disease, and also, because it's a CVD risk factor, these two parameters, he's also at risk for CVD progression. So my very next question is, what is the 10-year risk of cardiovascular disease in this patient? Well, what are we going to do? We're going to go to that prevent calculator. And because we can't see the information on the left, I filled in these boxes for you. So I put in his total cholesterol, his age, his sex, his cholesterol readings, his systolic blood pressure, BMI, his eGFR of 40, urine albumin to creatinine ratio of 350, which is very high, and hemoglobin A1C of 7.5. And you see that this individual has a very high risk, 10-year risk of CVD. So this patient, if we don't do something to manage him better, is likely to go on and have, an MI, a stroke, or other cardiovascular event in the future, or heart failure. So what proven strategies can we employ to reduce progression of CKD, but also address this patient's cardiovascular disease risk? Have any ideas out there? I'll just give people a few seconds to think about that.
Before we have the crowd answer, can I ask a question about that last on the prevent tool?
Yeah.
We may not know just off the top of our heads, but how would his risk vary from the ACC-AHA tool?
It typically, the old risk calculators will usually give a lower risk. And the reason is they're not incorporating the urine albumin creatinine ratio or the effects of the risk of low GFR. The one thing I also like about this, and I didn't point out, and this is all, for doing a good job for those with healthcare disparities, you also, if you know the zip code of the person, you can put that in, and then that will marry to areas of social deprivation or social economic, challenges, and that will put that into this equation as well. And I didn't know what this person's zip code was, so I didn't put it in.
So that would make a difference. Like for me, if I was recommending, it would make a difference. The zip code may make a difference on what I would want to recommend, because I hope he has really a good insurance on what I would, if I could recommend all the medicines I'd want.
Yeah, exactly. And that's some of the challenges that we're facing right now as clinicians, because, a lot of practitioners I'm working for are working in areas that are challenging because they're low income and they don't have insurance status, or they have not enough insurance, and we have to put them on medications that are not as good to reduce progression of these diseases. And it's a problem for me morally and ethically. And so, as a pharmacist, one of the roles of pharmacists and pharmacy technicians is really, I think, as well as social workers, is to help people access these medications where we can do the best job possible for our patients. But it's not easy. And it takes oftentimes a lot of time for the paperwork. So it's very frustrating. And that's why I can't wait for the generics, to start coming on with the pegliflozin, and I hear that liraglutide should be coming out in the next year or so. We'll start having some options in both the SGLT2 as well as the GLP-1RA categories. Well, I'm going to go on. I'm assuming I'm not seeing anybody coming to talk about the proven strategies, but this is what I came up with. So we know that for reducing both CKD progression and risk of CVD, that we need to address blood pressure and also albuminuria reduction. So we look at him, and let's go back to his list. I don't see, he's not on an ACE inhibitor and ARB. He's on 2 other blood pressure medications, which is great to reduce blood pressure. But one, we're not doing it. This patient's blood pressure is not ideally reduced. And we don't have him on one of the key therapies that we can use to reduce CKD and CVD progression. The second is because he has diabetes and because he has CKD both, that we want to start him on an SGLT2. So the 3 that have that cardiovascular and kidney disease protection effects. And think about a GLP-1 receptor agonist potentially sometime down the road, because both of these agents work to reduce CKD progression, and as well as some of the CVD health independent of that blood glucose lowering, because they have other effects than just lowering blood glucose. They have reduction in inflammation that reduces fibrosis in both the heart and the kidney. So these are two agents we should be thinking about for him. And then potentially, if using the SGLT2 and or the GLP-1 is not getting that albumin down lower, his albumin is over 350, then we would consider treatment with finerenone to try to lower that. It's another mechanism of action. It's a non-steroidal mineralocorticoid receptor antagonist, and it has the opportunity from a different mechanistic standpoint to help lower not only blood pressure a little bit, it's not as good as spironolactone for that, but to reduce CKD progression. So the way I think about these agents right now and where finerenone's place in therapy is always that first step, and really I should probably put the SGLT2 inhibitors too in this first step as really some of our first steps for addressing both cardiovascular and CKD progression. GLP-1 RAs, certainly, and somebody that has a high hemoglobin A1C, you might even be thinking about this first before an SGLT2, but SGLT2s still have the strongest evidence of all these agents for reducing CKD progression as well as decreasing cardiovascular risk. And then our third step, or I'm not calling it an alternative, because the non-steroidal MRI finerenone has two big studies that have shown that it can reduce CKD progression, but now there was just a new study released. It was called the Fine Arts study that showed that finerenone in patients with heart failure and diabetes, and about 50% of those patients had CKD, showed a reduction in heart failure. So this is going to become more of a standard of care therapy. So if they don't tolerate, for instance, a GLP-1 or potentially an SGLT2, it would be one that I would consider, as an alternative step here to those agents potentially. And then finally, what I wanted to do, I put this slide together and I thought, oh my gosh, this is so amazing just for my own understanding of how these medications help across this whole obesity to type 2 diabetes, heart failure, and chronic kidney disease type of scenarios. And what you can see here is you go over here, I'm going to start with CKD, which is on the right-hand side. You see ACE inhibitors here, under heart failure, ACE inhibitors, under type 2 diabetes, ACE inhibitors. Only place you don't see them is in obesity. And then the SGLT2 inhibitors, you see them all the way across these 4 areas of the CKM spectrum. Non-steroidal MRAs across the type 2 diabetes, heart failure, and CKD, the ones in yellow here. And then our GLP-1 RAs, you see it across obesity, type 2 diabetes, as well as CKD. And I actually added the GLP-1 and the GIP combination, so that's tirzepatide, under obesity, because there is just a big study, the SURMOUNT-1, that showed its effectiveness in reducing obesity as well as just the standard GLP-1 RAs. So that is exciting, and I think that will become one of the pillars of therapy for obesity. And since you guys know so much more about diabetes than I do, what do you think about this? I really like this, and I'd like to hear what you think about the combination therapies to hear the GLP-1RA and the GIP-RA. Okay, well, I'm not hearing anything, so I'm going to go on to wrap this up. I wanted a chance to talk to you about the Advancing Kidney Health Through Optimal Medication Management initiative. This is an initiative that I founded back in 2000, and now we have a number of stakeholders, which include pharmacists, pharmacy organizations, patient advocacy organizations, physician organizations like the Renal Physicians Association. We have nurses involved, students involved, graduate students involved. And so I think we have over 100 different either organizations or people involved in our organization now. And what is this, as I call it, ACOM, all about? Well, our vision is that every person with kidney disease receives optimal medication management through team-based care that includes a pharmacist. And what we are working with is nephrology practices, primary care practices now, we don't have a value-based kidney care company, but we want to be able to work with those as well. We're working with some health systems now to implement this comprehensive medication management and really focus in on this guideline-directed medication therapy for the CKM spectrum that I've just been talking about. So we've got two major pieces of our initiative. One is our CKM curriculum. We've got 21 online CE modules. You can see here, many of them focus in on the topics we've been discussing today. That is CKM management. There's 6 different modules that fit into that area. Symptoms in CKD, things like hyperkalemia management, deprescribing, and all of these modules are free for physicians, nurses, and pharmacists. I think this is the only curriculum that I'm aware of that we have integrally involved patients from the beginning of thinking about these modules as well as all the way through. And we've got a curriculum advisory panel that consists of pharmacists, nurses, physicians, patients that help us figure out how we frame these modules for busy working professionals. And then I think what I'm very excited about is our Learning and Action Collaborative. So we just initiated that in July this last year. We now have 7 teams across the US, which encompass healthcare systems, primary care practices, nephrology practices, and 1 federally qualified health center and 1 low-income health clinic. And all of these teams are working together with one another with coaching. So each team has a coach. We bring in field experts in nephrology, and they are focused on implementation, this guideline-directed medication therapy within this framework of comprehensive medication management. So they're focusing on patients with CKD or with CKM. And it's amazing to see because these teams are passionate. They're not even halfway through yet, and they have just been phenomenally successful in starting to integrate some of the key components like tracking medication therapy problems into their practice. And so we think at the end of this, we're going to show amazing changes. And I think what's so fun, just like with your collaborative, you see people and get people working together. It's amazing how they learn from one another. So we've learned a lot from them. They've learned a lot from our coaches and field experts, and those coaches, help keep them focused in on what their goals are that they've set and help them every month in pacing events work through those goals. So I'm going to leave it at that and then open this for questions. I'm just very excited again to be here, and I want to thank you. And if you have any questions, here's my email, either about this presentation or about our initiative.
This has been absolutely great. I'm going to have to get off in just a minute because I've got to get ready for another meeting. But Dr. St. Peter, I wish I'd had some of our patient groups here because they're very much wanting to learn about this. And I loved your slides. So I just wanted to say thank you really for presenting today.
Oh, you're very welcome.
Yes, thank you so much. I see a lot of thank yous in the chat. Is there any way that you can put the link to the website for the CE and education program you had?
Absolutely. I'll put that right in the chat.
There may be some of our colleagues in clinic who can't come off mute, but if anyone has additional questions, please feel free to, okay, so it's www.kidney.
Medicationmanagement.org.
Okay, perfect. All right. And we'll be sure when we post the webinar, we'll be sure to put that link there with your resources as well, because I know a lot of our audience would be really interested in that additional education. So thank you so much. And if anybody has additional questions, please feel free to directly email Dr. St. Peter, or you can email us at Tennessee Heart Health Network, and we can coordinate with her to get more education for you all. I know we've got some of our colleagues from Department of Health who are really working hard on diabetes initiatives, heart health initiatives, kidney health. It's all really the same type of thing that we're working to improve the health of Tennesseans. And then we appreciate everything you're doing in Minnesota, as well as nationally and internationally, Dr. St. Peter. So thank you for being with us today.
Oh, thank you for listening and participating. Bye-bye.
All right, bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.